I think toxicity is the number one consideration. Of course, every woman will tell you that when presented with the choices of getting a toxic treatment for a period of time that affect obviously the hair, the risk of infections and so forth, versus a treatment for an indolent disease for a number of years, sometimes even more than 5 years, they will definitely choose to really get the one that is favoring their quality of life. And there have been studies in the past looking specifically what's the improvement in quality of life years with chemotherapy according to age. So now we introduce a new factor that is associated with understanding the biology of the disease, along with obviously the age of the patient and some of the standard characteristics, in order to define quality of life. That this patient can be cured, it can be managed for a long time without recurrence, with standard endocrine therapy, when we absolutely are able to define the risk and the biology of the disease. And I think this is more and more useful. On the other side, there have been some patients that have been identified as high risk of genomic tests that were otherwise considered by clinical meaning because the tumor was certainly not large and not looking aggressive under the microscope. But the molecular feature indicated that these patients will need chemotherapy. So we need to be able to give the chemotherapy and the aggressive treatment that affect the quality of life to patients really deserve, because the molecular feature of the disease is such that will recur. That way we can prolong the life of the patients and we can certainly improve. So essentially the implementation to a large scale of precision medicine for primary disease.